the regular? Yeah, they gave me the regular. Which one? The one that's open? Okay. I had some extra in my
Are you ready? I call this meeting to order. Mr. Hidalgo, can you lead us in the pledge, please? Followed by a moment of silence. All right, thank you. Madam Secretary, can you call the roll?
Mr. Lejeune?
Here.
Mr. Davidson?
Here.
Ms. Mason?
Here.
And Mr. Hidalgo?
Here.
All committee members are present. There are no other board members at this meeting.
Thank you. All right, moving on to our agenda, we have item 2.1, review and approval of LPSB Board Insurance Committee meeting minutes on May 13th, 2026. Do I have any public comment? Okay, sorry. I need a motion.
Move approval.
Thank you. All right, second, anyone?
Yes, I'll second it.
Thank you. We have a motion by Mr. Hidalgo and a second by Mr. Lejeune. Do we have any public comment? Seeing none, do we have any board comment? All in favor?
Aye.
Any opposed? Motion passes. All right, moving on to 2.2. Discussion and or action regarding direct contracting. Kelly Cox of HIC Holding Corp. will present on direct-to-employer contracts. Direct-to-employer contracting is a strategic alternative to traditional insurance networks. Under this model, Lafayette Parish School System contracts directly with local hospitals and physicians for medical services. By eliminating third-party intermediaries, this approach allows Lafayette Parish School Systems to secure more favorable rates, control healthcare spending, and establish direct partnerships with local healthcare providers. Mr. Cox will present a comparative performance analysis of the direct-to-employer contracts, contrasting calendar year 2025 data against year-to-date 2026 metrics. This presentation will evaluate the claims performance in order to measure the strategic and financial impact of the direct-to-employer contracts.
Madam President, if you don't mind,
Yes.
I'll start. Okay, so first of all, board members, members of the public, just wanted to kind of give you guys an idea that a lot of what we're going to hear today is going to be from Mr. Cox and also from Gallagher on first quarter, second quarter reporting as far as where we are since we have taken over as far as Meritain is concerned. We have new PBMs. We are into these direct contracting. And these are a lot of different initiatives. Tria Health is here. A lot of different initiatives that the board has actually gone through. And this is a true task for our retirees and our members of the public that are out there to see if those measures are actually showing the results that we thought they would based upon the decisions of the board. So starting off is going to be our direct contracting. Again, this was an idea that kind of came to us when we started working on, first of all, getting Gallagher on. Gallagher is our TPA. They're basically, not our TPA, our consultants that basically manage our healthcare. And when they actually were bidding for that work, there was Mr. Cox who came in and started talking about direct contracting and about what that would look like. And that was the first I ever heard of that. And doing research, believe it or not, these are things that are being done not in this area, but in this country. And it was something that on the alternatives of what they were doing as far as Gallagher and working with our new TPAs, Meritain. Again, Meritain was the reason why we went with them, is because the idea that we can direct contract. Understand that whether we were liking it or not, Blue Cross would not allow us to do that. They said, you will not do any direct contracting. So when we started looking at this direct contracting, we started saying, who are the major players as far as who is getting the most business? And what we did is we went and we attacked those particular individuals. And what happened is we sat down with Oshner, and we sat down with Park, and we sat down with all of those different individuals that you're going to see on the screen in a few minutes. And we said, hey, I don't care what Meritain is giving you or what we have as far as a deal with Aetna on Verity. We want something better than that. We want something on top of that. And basically, they said, okay, or some of them said, oh, we need to go back to our execs and so on and so forth. So in these particular numbers you're going to see, I am cautiously optimistic that whether what you hear from Mr. Cox or you hear from Gallagher, that some of these measures are actually showing that we may at some point get a fund balance. Retirees, you hear this? We may at some point be in a fund balance. So I wanted to just kind of set the stage, because this is one of the two, and you're going to see the numbers, because I'm going to tell you, when I saw the numbers, I went and I said, go check it with Meritain. Go check it with Gallagher. I want to make sure that we double check these numbers, because it is what it is. The numbers don't lie. And it comes down to is a lot of people have been speculating as far as, is this true or not? These guys are going to start off with, and I'll give it to Mr. Cox.
Thank you, sir. If we pull up here, I've got a snapshot, just a one-pager of, as was asked, just a comparative analysis. And as Francis has mentioned, I want to make sure that we qualify the remarks here, and I don't want to speak for Gallagher, but I know that we're early on, right? I mean, this report reflects January through the end of May, and while as Francis said, the numbers are the numbers, and the information is clear. I'm not at a point 6 months in where I can say that we've found the golden treasure, but from the looks of this and from the details, it certainly appears that we are on the right path, and so that is really good news. The report here you see is pretty self-explanatory. These are entities, and we're comparing 25 numbers, and again, this is a little inside baseball, but these are what we refer to as incurred and paid claims in the January 1 through May 31st timeframe. What that means is that the claim was incurred on January 1 or after and was paid in that timeframe. So I want to make sure that, if you looked at, there are, and I don't want to get too far into the weeds, I know the team following me will probably speak to this. This is not all of the claims that are being paid, and what happens is you have run-out claims that were incurred in 2025 that don't get paid until 2026. But for purposes of the work that I'm doing, that really doesn't impact me, so I'm reflecting what the reality is here from January 1 through the end of May. So with that being said, there is one note here at the bottom left-hand corner. There's been a slight decrease in census count, just a little over a point. So there's that to factor in, but when you do the calculations of cost per employee per month, that factors that in. So what you see here is across the board, fairly significant savings totaling a pretty good sized number. Again, I think we're in the early phases, and we do these kind of meetings all the time, usually at the mid-year point, and first year in, they are an indicator, and I would say that is probably the gist of it, right? So once we are year end, and we can look back at a full year's numbers, I think the picture will, I know it will become a lot clearer. And so we continue to monitor these contracts and these providers, and not just the total amount of claims paid, but the number of visits to the providers. And I think those are significant as well. So I don't know if there are any questions regarding the report and what you see here, but
Let me add that, again, I was pretty shocked, and I'm going to draw everybody's attention to Lafayette General. So when you look at Lafayette General, and I'm saying to myself, that many people on our plan is going to Lafayette General as far as Verity is concerned, and evidently that, again, is a big user, whether it be here or their different affiliates, so on and so forth, but evidently that is the case. But I also look at, okay, so let's look at Lourdes. Lourdes outpatient, Lourdes inpatient. And just looking at the difference as far as, hey, that's still $392,000. It's still $189,000. When I look at Acadian Ambulance, everybody uses Acadian Ambulance. Again, we see that there's $120,000 that is something that is savings compared to last year. And all I'm saying is that I'm cautiously optimistic, and I don't want to basically say that, hey, next quarter or whatever, that we'll see the same thing. But this is telling us that we may be, because what you're fixing to see from Gallagher is some of the same story, that they're going to actually show that our health insurance finally is getting to a point where it's reflected of we're getting our employees better care, and we're making sure that we're saving money on the back end.
Yes, I would agree, Francis. I think, all indications, as I stated earlier, is that I think that we are, for the first time in a couple of decades, looks like we are on the right path, and hopefully we will stay there. I will say this, just to qualify it once again. Reinsurance carriers will tell us that every 3 or 4 years you will have a bad year. And so in that time frame, you're going to have some good years too. So it could just be that we're having a good year. But when you look at the claims themselves and you look at what's going on with the discounting, it is significant. And so it's stepped up. And so that's why I say I would mirror Francis's comments of being cautiously optimistic, but we'll keep our fingers crossed and keep working at it. But I think we're on the right path.
I have a question.
Sure.
On the chart where it says Lafayette General, and you have down 88%. Can you explain to me in simple terms, what does that mean, down 88%?
Well, if you look at the, David, if you look at the claims that were paid in January 1 through May 31st last year with Blue Cross versus the same time frame this year, there has been a little over a $2 million reduction in claims paid by LPSS to Lafayette General.
Okay.
Yeah, so it's pretty straightforward here in the report. I mean, there's obviously this is a compilation of a lot of data, but yeah, that is, as Francis said, that's a significant number, and but we knew going in that that Verity is strong, and they're proving it. Plus, other work that we're doing. So that number definitely sticks out.
And where it says Lafayette General, that's a reflection of their whole network of doctors and.
Well, no, that is just that facility. That's just that
facility.
Just that EIN on in and outpatient claims, and so yeah, no, that is just the hospital.
Okay, so it's not a reflection of all of the network of
doctors.
No,
and listen, so and I'm pretty sure Gallagher will speak to this, but that is going to be a reflection of the network downstream as well.
Okay.
So yeah, that's, they're a proven entity, and they do a good job. And as I said, I think a couple times before, I'm very familiar with them and know how they work, and we've had a lot of success, so that's not a surprise.
Now, in the future, what can we expect more contracts from other medical facilities around town?
That's a good question, David. So one of the things that was present initially is, you know, when you move from a Blue Cross, access is going to be an issue, right? And so with a combination of Aetna and Verity, access really was not and is not a problem. Now, is every provider in Blue Cross in one of these two networks? No. Are there providers in these two networks that aren't in the Blue Cross network? Yes. But we're not talking, we're talking about a very small variance, right? So you start from a point where access is, because look, I mean, we all know this because we're patients too, right? So I call it the easy button. I mean, everybody likes the easy button where you go in and you show your card. The person behind the desk that's doing the intake recognizes a logo. There's no questions, no issues, right? So that is something that members and retirees certainly want to see. So we had that working in our favor. So as Francis said, what we wanted to do was look at, okay, where is the bulk of the dollars going, and how can we leverage that to do even better, right? So if you have access, and then you can work on, okay, what are we paying these providers? Where's the money going? Then that's when you start to get into the right direction.
So this is ongoing, though. This is not all we have. This has the ability to continue to be ongoing.
It is, and so what happens is on a regular basis, I will have providers reach out to me, and I always say the dynamic is such that if a provider is reaching out to me, that's not really a dynamic that's going to be helpful to LPSS if you follow the thinking, right? It's us having to go, again, you look at where the money is, because access is not a problem. So if you have a provider that's, I don't want to pick on any specialty, but in a certain specialty, and you've got, between the two networks, you've got 50 providers in there. When one calls in and wants to wants to talk about contracting, well, the obvious response is, well, you've got two networks. I mean, have you contracted with them first? So that's a starting point. So, you know, when you're talking about individual providers, it's really those, and there's because the access is in the network is so complete, there really is not a lot of gaps or holes in it that we need to fill. But those conversations still exist, and people want to reach out because they know when they do that, the reason they're doing it is because it's going to draw traffic to their door, right? So you understand the dynamic of why they're doing it, but is it really helpful to LPSS and the member? That's the whole task, right?
So Mr. Luzerne, I think the quick thing is that, number one, this is going to be ongoing to where when we start looking at claims coming in from Trish and what Gallagher has provided, we're going to say, listen, a lot of people are utilizing not just these 6, but this other one over here. Hey, let's go see what we can do as far as trying to save money at that one also. So we look to see, these are the big ones based upon what we saw before. And all I'm saying is that there are others that we may be able to go and, on top of what we're getting with Verity, on top of what we're getting with Aetna, let's go and say, hey, give us more, because I'm going to tell you, this is telling us that Lafayette General, whoever's using Lafayette General, we're getting the best deal. We're getting the best deal. Lafayette Parish School System, who is the insurance company, is getting the best deal. This is the money that we're having to not put out.
I have a question. Sure. So you were saying that providers reach out to you, or they reach out to LPSS, to our insurance department?
Both.
Okay.
So I'll have, Trish will send people to me, and then people become aware that I'm doing the work through other avenues, and they'll reach out directly to me. So yeah, it happens both ways.
Okay. I've gotten so many questions about this from the public, from the press, from a lot of people. How is what you're doing different from what we're already paying Gallagher for?
Well, it's different because Gallagher is not doing direct contracting, right? So they are managing the plan and controlling your assets, which is their job. That's those of us that are in the broker TPA space. Their job is to control your assets, which is what they're doing. This is a more, I guess, it's a separate, but maybe a deeper dive into specific providers, and you're having one-on-one conversations with them to try to get the most out of these.
Right.
And
So
that
is this different? So Gallagher can't do this for
they
us?
they would have to speak to that. I mean, that's, I believe that's why I'm here, though.
Okay, I'm just trying to understand and answer the public's questions
Sure.
on what does Gallagher do for us, because we already had a contract with them, and then, why did we hire another person
Mm-hmm.
to come in? Do you want to come up? I'm trying to provide clarity for all the public to understand what's happening.
Yeah.
Sure.
Yeah, so we have direct contracting experts and consultants. We are just employee benefits, our team alone. We have the experts in that space. However, we don't have any that are local. And we felt it was important to say no on your benefit, not to participate in that project, because we don't have someone local in this area. So we basically said no to that project.
Okay, so that's a little bit clearer.
Yeah.
Okay, thank you. All right, do we have any other board comment? Okay. And there's no action on this item, so we're
Good.
going to move on. Thank you, Mr. Cox.
Thank you.
We're going to move on to item 2.3. Discussion and/or action regarding Tria Health. Tria Health will introduce their program, highlighting how their pharmacists collaborate directly with members to optimize medication effectiveness and manage chronic conditions. Additionally, they will present an analysis of participation rates, enrollment trends, and financial performance, demonstrating the program's measurable impact on healthcare cost savings and the overall budget. All right, there you are.
Yeah,
Thank
hi.
you.
Thanks for having me here. I'm Katie McGilly. I'm with Tria Health. I'm your senior account manager with Tria.
Just a second. We're going to make sure your
Okay.
mic is all the way up.
Okay.
I have the same problem. Okay, try again.
Can you guys hear me now?
Much better. Just make
Awesome.
sure you're right into the mic.
For sure. Okay. Thank you. Okay, so thanks for having me here today. Today we're going to walk through our 2025 annual report, looking at financial outcomes as well as clinical outcomes, and then also look at Q1 pacing with financial and clinical outcomes. I think I'm getting shared on the screen. I apologize. Thank you. Okay, so just a little bit about Tria. Sorry for the technical difficulties there. We're a clinically driven pharmacy solution, which is going to work with members who have chronic conditions to help them get the most out of their medications while also lowering overall healthcare costs. At the center of what we do and what we'll look at today is our Pharmacy Advocate Program, which connects members with our team of clinical pharmacists for one-on-one phone consultations to help optimize their medication and overall care. With our Pharmacy Advocate Program, we engage with people with a variety of chronic conditions. And since chronic conditions are managed with medications as their first line of defense, a clinical pharmacist is really a valuable resource to help make sure those complicated regimens are managed properly. So today's report will kind of walk through first the success stories, then we'll look at financial outcomes for 2025 as well as projections for Q1, and then engagement and metrics around that program as well as the clinical monitoring programs. So here's kind of a snapshot view of the TRIA health benefit and how all of the pieces work together to simplify care. Our foundation is going to be that core pharmacy advocate program paired with our RX plan protection suite. That is a pharmacy cost containment benefit that looks at the plan as a whole for different opportunities to optimize medications and reduce unnecessary costs at the pharmacy. Our focus, again, is really on collaborating with those members that have chronic conditions. We engage members with a variety of chronic conditions, including asthma, COPD, high blood pressure, high cholesterol, heart disease, mental health, osteoporosis, pain, and specialty conditions, as well as migraines. And the members are identified as eligible for TRIA if they have any of these conditions or they're taking multiple prescription medications. And then around that core pharmacy advocate program, we also offer remote monitoring programs for members that have diabetes or members that have hypertension. So on our diabetes monitoring program, members can receive a free cellular blood glucose monitor and testing supplies. And for those hypertensive members, they can have a free blood pressure cuff. All of this lets them track and share their readings with their clinical pharmacist, as well as see trends and different insights as it affects to their medications within a digital dashboard. So we'll start out with some patient success stories. All of these are specific to LPSS members who are engaged with TRIA, and then all member details have been de-identified, and any stock images you see are going to be just stock images. So this first one really highlights the benefit that a member working with a clinical pharmacist had on effective pain control through a simple dose adjustment. And it ultimately...
Put it in presentation mode so they can see your just go to view. Slideshow. There you go.
There we go.
See your words.
Okay, thank you so much. So this is a story about an effective pain control through a simple dose adjustment that one of our pharmacists helped with. So a little bit of background on this member on that patient profile. You can see they were dealing with a complex medication regimen, taking 11 prescription medications, 1 additional over-the-counter, seeing 4 total physicians to help manage 7 conditions, some of which included high blood pressure, high cholesterol, mental health, and heart disease. This is the exact type of member that TRIA is here to help. So during this member's consultation, when they were working with their pharmacist, they shared that they had been experiencing uncontrolled pain that had actually recently landed them in the hospital. To manage that pain, they had been taking pregabalin, 75 milligrams twice a day, as well as duloxetine, baclofen, and but they had remained in severe pain and ended up in the hospital. When they left the hospital, they were prescribed an opioid, but they chose not to take it. And that's where TRIA stepped in. We did a deep dive and a medication review, also looking at their chronic conditions and how that all played together. And we noticed a simple switch could help manage their pain without having to add in that opioid. We made a recommendation to increase the pregabalin to 150 milligrams twice a day. Following the consultation, TRIA's pharmacist shared that care plan not only with the patient, but also their prescribing physician for review. Their doctor ultimately did agree and made that switch in their medication, and ultimately kept that member from having recurrence of severe pain and out of the hospitalization. And then the second story also highlights a simple switch that optimized health outcomes. This one is pretty unique because it also involves our diabetes monitoring program. So this patient was taking 2 prescription medications and seeing 1 physician for 2 conditions. When they engaged with TRIA Health for the first time, they were newly diagnosed with diabetes about 4 months ago. Very complicated and confusing time starting to deal with one of those chronic conditions. They also hadn't started taking their blood sugar at home prior to meeting with their TRIA pharmacist and had just begun taking Mounjaro 2.5 milligrams a week. So they had their consultation with us, and we were going through their medication review and realized that the dosage of Mounjaro they were on is actually just an introductory dose. It's not meant for long-term use, has no real therapeutic benefits to lowering blood sugar. So we made the recommendation to their doctor to increase the dose as tolerated to help improve those numbers for them. And the doctor agreed with that as well and made that adjustment. The patient's blood sugar readings are now averaging 92 milligrams a deciliter, which is well within range, but also they are now in TRIA's diabetes monitoring program, which allows them to track and share their numbers with their pharmacist and get those free testing devices. We do attribute this to an outpatient visit avoided for this member since TRIA coordinated the care directly with their doctor. They didn't have to make a doctor's appointment, go in and do all of that to get the medication adjusted. And then we did see strong financial outcomes for 2025, and I've also got some Q1 projections here, so we'll look at that. So looking at the savings and investment summary, you'll see it's broken out 2025 as well as Q1 of 2026. As an overall ROI for 2025, we did deliver a 2.4 to 1 with the claims validated prescription savings, more than paying for the program on their own. And then looking at projections for 2026, we are showing a 3.4 to 1 overall ROI, which is driven by the increase in engagement, which we'll show here in a minute. But the claims validated prescription savings also more than paid for the program on their own so far this year, which is great. So we report savings on a few categories, as you can see there. Our prescription savings, again, are claims validated, and they're really driven by medication optimizations, including moving members to lower cost, clinically appropriate alternatives, discontinuing unnecessary duplicate therapies, and resolving different drug therapy issues that they're experiencing, which lowers overall pharmacy spend across the board. And then we also have healthcare savings. This is going to be really similar to those success stories we saw earlier. So we're only ever going to take credit for a visit when we're able to see in claims that a return visit was avoided following 90 days of TRIA's clinical intervention, helping coordinate that care. So we see a lot of things like outpatient visits avoided for dose adjustments, changing medications, hospitalization visits avoided, urgent care, those type of things. We also report on compliance savings. People with these uncontrolled disease states can be costly to a medical plan. So for members that are working with TRIA and they first came into the program and they were uncompliant, and then we were able to see and track through claims data that they became compliant as well as stayed, we show savings there. And then the last saving for the clinical program, that's going to be for remote monitoring metrics. This is going to be attributed to members in either of those diabetes or blood pressure programs that have significant drops in their A1C or their systolic blood pressure. And then at the heart of what we do is our pharmacy advocate program where members get to work with their doctors of pharmacy. So we're going to look at engagement. Very pleased to see continued growth here. So we do have it broken out quarter over quarter. That last section there, I wanted to provide the most up-to-date information we had. So that is current engagement as of the end of June. So you can see we ended 2025 with 262 members engaged. 122 of those were retirees. And then we're currently up to 325, which is really driving those savings we're seeing in Q1, and we'll see progress throughout the rest of the year. In that chart below, you'll see the total members that we collect from eligibility, and then you'll see those that we have identified, non-engaged, just kind of against a benchmark with our book of business. We typically see about 20 to 23% of a population identified as eligible for TRIA, and we are identifying a lot more people on Lafayette's plan, so it's great to see we're getting the right people involved in the program, those that have the chronic conditions and take 2 or more prescription medications. And then that average engaged member profile there on the right is specific to LPSS. This is for members that are engaged, working with their pharmacist, kind of what they're dealing with. So on average, they take 9 prescription medications, an additional 2 over the counter. They're dealing with 6 total conditions, with right about 3 of those being one of those targeted chronic conditions we specifically identify for. And then on average, they're working with about 2 drug therapy problems per member that's working with a clinical pharmacist. And so a drug therapy problem is going to be any type of clinical problem related to the use of medication that ultimately keeps that member's disease from being in a controlled state. So this can be for things like adverse drug reactions, so any unattended side effects that they're getting, issues of compliance, dose too high or too low, or any unnecessary drug therapies. And then I did want to just kind of include this here. LPSS has a fantastic incentive for members who engage. They can get free generics or reduced costs on name brand medications that treat their chronic conditions. They just have to engage with TRIA. This is by no means a comprehensive list. It's just meant to give kind of a bird's eye view of what type of incentive is available.
Can you go back to that and can I ask you a question?
Yeah, of course.
So explain to me about these medications and who's eligible to be on this through the parish, and how is this beneficial to the average person on the insurance plan?
Yeah, definitely. So anyone who's eligible for TRIA, if they have a chronic condition or are taking multiple prescriptions, they meet with their pharmacist, they receive a secondary card that they can use at the pharmacy. It also lives in their app. But there's real savings tied to that, since most members are taking on average 9 prescription medications. Getting a free generic or a reduced cost on a name brand medication can save them a lot of money at the pharmacy.
So you, as the person on the plan, would meet with your pharmacist?
Yes, yeah, they would just hold a phone consultation. They hold one about every 6 months. And as long as they stay engaged and they're having those appointments, they keep getting the savings.
So who's eligible for this?
Members that have chronic conditions, so if a member has high blood pressure, heart disease, high cholesterol, diabetes, it includes mental health conditions, osteoporosis, migraines. If they're taking prescription medications, they're eligible.
And this would be, those people you would go through your doctor to make sure that you're eligible for this?
We ingest claims data, so they can call us, and
Okay.
we would know if they're eligible. They can reach out to TRIA.
Okay, thank you.
Yeah. And the last section here is just kind of a bird's eye view of remote monitoring metrics that we saw for the 2025 year. So we did have 49 engaged in the diabetes monitoring program. Again, we've seen real growth there. We're up to 56 users. And we had 8 pharmacist interventions. It's when a number comes in either too high or too low. It alerts their pharmacist, who reaches out, sees what might be changing those numbers. If they need to seek care, they help them do so. The average A1C for the group was well within control range, under a 7. And we did see an average reduction of 2.33, and then we did have 5 users have a 1 point or greater drop in their A1C. And then for the blood pressure monitoring program, we ended 2025 with 101 active in the program, tracking and sharing their readings using their cuff. We're up to 113, which is great to see. We did have 41 pharmacist interventions for out-of-range readings. We do see that typically a little bit higher than diabetes monitoring, just because there's so many things that go into blood pressure, and there's sometimes a learning curve with how to take your reading properly. So their pharmacist will reach out to them and help them take the proper reading, and if it's too high and it really is concerning, they help them seek care. And then we also had 14 individuals who had a 10 millimeter of mercury reduction in their systolic blood pressure, which we know lowers the risk of cardiovascular events by about 20 to 25%.
And again, board members, this is one of the things that you guys voted on and passed to be part of our plan, to be able to help curb some of the costs as far as medicines are concerned.
So can I ask Ms. LaBeouf, is everybody that's part of our insurance, our active insurance plan, are they eligible for this if they have a chronic disease?
Yes, sir. Both your active members and your retirees are eligible for this program. Typically, they're notified by a blue envelope that comes directly to their doorstep that lets them know that TRIA Health is trying to connect with them. TRIA also reaches out via phone. But yes, it's open to dependents, active members, retirees, those who are eligible with those chronic conditions.
Now, how about the people that have switched to Humana? Are they eligible?
No, sir. No,
Okay.
TRIA does not coordinate with your Humana plan.
Okay. And does this cost any more to be
There is
part
a
of?
per employee per month charge that the district does have a budget line item for. Is that what you're asking?
No, I'm asking if the individual has to put any money towards this.
No, sir. No money. Oftentimes, if the member connects with TRIA, speaks with their pharmacist, their licensed pharmacist, their prescription costs, if it is one of those eligible drugs, sometimes the prescription goes to zero with a zero copay. Sometimes it drops by half. It really just depends on the prescription and those consultations directly with TRIA.
Okay. All right. Thank you so much.
You're welcome.
Do you guys have any more questions for me?
Any other questions? Okay, thank you so much.
Thank you.
All right, we're moving on to item 2.4, discussion and/or action regarding Gallagher Benefit Services. Ms. Gardner or Ms. LaBeouf? Or actually, Gallagher is going to present. Gallagher Benefit Services will provide updates regarding financial summary, Medicare Advantage marketing analysis, wellness incentive modeling, and the service calendar. Thank you.
My apologies. Give me a moment. It's working. Is that good? Yeah, I'm just doing it like that. Hi, I'm JB Murphy. I'm the consulting actuary at Gallagher. This is Eric Pearson.
Yeah, Eric Pearson, thank you for having us.
Yeah, and feel free to interrupt with any questions as we go along. There's a lot on here, so. I'm going to go through the financial summary. So what we're looking at first is a year over year for fiscal years 23, 24, 24, 25, and then 25 and 26, which is what we're currently in. And just kind of outlining what's on the page. In the top section, there's a month by month of gross medical and RX claims. In the second section, there's a total for gross. You need me to get closer?
Sorry, just get a little closer. Can you turn up his mic just a little bit? Thank you.
All right. So at the top section, there's a month by month for gross medical and RX claims. In the second section, it's totaled for gross claims, and it nets out RX rebates and stop-loss recoveries to form a total net claim. Once you levelize for being on a per-employee basis, we've seen a drop from 24 to 25 to 25 to 26 of 9.71%. Once you include fixed costs, it drops by 7.5% year over year. On this slide, we're looking at a January through May 2026 comparison to January through May of 2025. It breaks it out by total in blue, class in green, and plan in orange. And at the very bottom, you're going to see the Humana MAPD premium. Note that this is on a per member basis because Humana reporting was done on a per member, and we wanted it to be an apples to apples comparison. You're going to see a drop year over year on the far right-hand side. We're attributing some of this to claims immaturity, but we're hopeful for the rest of the year, cautiously optimistic. Using an analogy, this is somewhat similar to an MLB season where you play from March to October, and we're in March and April and May, and things are looking good. We don't know where we'll be in October, but we're hopeful.
So if we stay on this track right now, we've had a deficit since I've been on the board. Will this put us at a surplus if we stay on this track at the end of the fiscal year?
If we continue exactly as is, then yes, but there's claims immaturity, and I don't expect that to fully happen, like to say at exactly this level.
Okay.
But like I said, we're hopeful for the full year. This slide shows a financial summary for January through May of 2026. It's broken out by gross claims, pharmacy claims, rebates, and it's rolled up into a total net claims. It also includes a fixed cost. You'll notice on the medical line that there's a dip in February, and this is where the Louisiana Blue runout has kind of tapered off, and the Verity and Meritain is slowly tapering on. You'll also notice that the RX claims are at 0 for January and February, and that's due to the lag between processing and payments of Optum. But we expect that pharmacy is fully up to speed at this point. This slide is similar. It's very rolled up, but it's based on a fiscal year basis, so July 25 through May of 26. It does an actual cost comparison to the Gallagher recommended budget, and it also does an actual cost comparison to the LPSS funding allocation with the employee and the employer portion. We're going to switch gears a little bit and talk about Verity and Meritain. So there's two aspects to this slide. The top portion is a table outlining the projected savings done a year ago for Verity and Meritain, and we projected $2.6 million in savings. $600K is attributable to administrative savings and $2 million to a network discount savings. In the bottom graph, there's a lot going on, and I'll kind of point to a few things, but we're going to go into a little bit more detail on the next slide. But effectively, what we're looking at is the reported discounts in 26, and we have reporting from March through May. The green bar, kind of at the top, the solid line, is Verity. The bottom orange area is Meritain, and the purple is the combined average. You'll also see a blue dotted line, and that's the Louisiana Blue expected discount.
Question. So this is not including the summer months, right?
If you can count May as summer.
Okay. Well, I think that most of our employees get a lot of their doctor's visits done in the summer. So, I mean, that's
Yeah.
a big cost. So I'm just worried that this might be showing a false trend, you know, because we haven't included this year's summer months yet.
No, we call that seasonality in the industry. But one thing I can say about that is even if in some world there was a huge drop or a huge spike in claims, say that discount would expect to be comparable. The allowed to charge dollars, which is what this represents, isn't super it's not affected much by seasonality, let's say that.
Okay.
Sorry for all the jargon. This ties back to the prior slide, and it's a table of first the Blue Cross expected discount, which was at 64.1%. Then we have the Verity and Meritain expected discount that we set about a year ago, and we set that at 69.1% based on our analysis, where we thought Verity would be at a 70% and Meritain would be at 66%. The actual discount so far, based on the March through May reporting, is 67.7%, with Verity coming in better than we expected at 71.8% versus 70%, and Meritain coming in worse than expected at 58.8% versus 66%. There's some network utilization metrics at the bottom. And so as a percent of charge for Verity and Meritain claims, we're seeing about 2/3 are going through Verity, and about 1/3 are going through Meritain, and about 0.5% are out of network. On a paid basis, so that includes the Blue Cross run out, about 1/3 of paid claims January through May of this year have been Blue Cross, but we expect them to have severely tapered off. There's a chance that you always get a large claim come through later, but based on IBNRs and classical IBNRs, it's probably about 99% complete. We're going to do a little bit more comparison between 25 and 26. And so this is comparing gross medical and RX and a combination of the two. And so in the table in the top left, I'm looking at 2025 claims, 2025 through May, and then 2026 through May, so we can look at things on a like-to-like basis. Like you said, that at different points in the year, claims could be higher or lower, especially for somewhere like a school board. In the top right, this is kind of the most important graph I want to show you, is that in the blue, we're looking at 2025 claims throughout the year on a per employee basis. And in the red, it's 2026 on a per employee basis, and it's materially lower. We expect a certain portion of that to be attributable to the Meritain and Verity discount, and we expect a certain amount due to claims immaturity. We have yet to see with the rest of the year where that will end up. In the section below that, you'll see RX net of rebates, and in the section below that, you'll see a combination of the two, medical and RX. Here's a side-by-side of the top providers and facilities on a percentage of total medical. 2026 is of course, January through May, and 2025 is full year. It's broken out by inpatient at the top and outpatient at the bottom. Note that the 2026 claims are for Verity and Meritain only and do not contain the Louisiana Blue runout.
So this right here is a true indicator of what was done in 25 compared to 26 as far as how the reduction is, because I'm just looking at Lafayette General Medical, 9.4, but when you look at here, it's 2.7. Is that what you, I'm looking at the very top.
So 9.4 in 2025, and on the other side, it's 2.7. Note that this is inpatient claims.
Yes.
Claims are immature, meaning that when you switch carriers, it's not just an LPSS thing, it's across the industry. When
Understand.
people switch networks and carriers, claims can come in at different speeds, slower. I
Okay.
don't want to call it processing issues, but it can take a little bit longer. So we don't know where this left side will end up.
Okay.
And it's a percentage of your total medical spend is going to these different providers. Yep.
I'm gonna ask again about Lafayette General. Is just this the hospital, or is this the whole network of doctors?
I believe that's just the hospital.
Whatever's billed under that EIN for the hospital. Okay, we're going to shift gears a little bit just to talk a little bit about administrative stats with Meritain, customer service, and then we'll also take a little deeper dive into the Meritain network as well on the next two slides. So just to hit a couple of the highlights on this slide, this is from Meritain. So just customer service matrix that they've received 510 member calls. They've received 1,638 provider calls. Member service level is 98.64%. Average hold time, according to Meritain, is 32 seconds, and average speed of answer is 3 seconds. The member inquiries were mostly around claim status and processing, coverage and cost questions, and network verification were what the members were calling about. The providers were calling about claim status and payment, benefit verification, and then, of course, pre-certification. We just saw on the previous slide the top providers are Our Lady of Lourdes Physician Group, Osher Lafayette General, Lafayette Health Ventures, CIS, Cardiovascular Institute of the South in Homa, and then Acadiana Women's Health were the top providers. On the far right, claims processing, they processed 4,520 claims, 2,195 were medical, pharmacy 2325 claims, active claims, retiree claims, and in claims processing, 90% within 2 days and 92.5% within 10 days. And then you can see the financial breakdown. Active claims, 589,000, retiree claims, 487, about $230.25 average claim value. Okay, just this is from Verity, so just a couple of updates on Verity. It's nice to see that 2/3 of the claims are going through this network. The average discount, you can see at the top left, 69.7% for facility, professional 62.4%. The direct arrangements that are noted here are those providers that are not in Verity or the Aetna network. So when Mr. Cox presented his percentages, those were year-over-year total spend from 25 to 26, not average discount. These are average discounts for providers that are not in Verity and not in Aetna. So a little different as far as the way the two reports were shown. In looking at the far right, Verity has added since January 1, 2026, 44 new providers. And you can see the different categories: cardiovascular, 8, mental health group, 7, mental health nurse practitioners, 7, allergy, and then professional counselors. So they are adding providers as the program continues to progress. Any questions? All right, thank you.
Thank you. Good afternoon. I'm loud, so I don't have a problem being
appreciate
quiet.
Thank you.
Okay, next item on the list that we'll talk through is your Medicare Advantage marketing analysis. So every year you guys receive a renewal, right, from Humana. And let me, oh shoot, how do I do this?
Can you use the down button?
Down? Okay, that'll work. All right. So So, of course, with everything that's going on in the Medicare space, we, of course, anticipated an increase in the renewal. That is, of course, because CMS and the federal government is requiring more enhanced benefits on the pharmacy side, as well as some transparency regulations and laws that are happening behind the scenes. So in our market, we are anticipating basically an increase for all of our clients that have a Medicare Advantage program in place. So because of that, we go out to market every year just to look at your options. The last thing we ever want to do is disrupt your members. I know your members that are enrolled in this Medicare Advantage program with Humana do appreciate it and like it, but we still want to leverage the market in order to come back and try to receive as much savings as we can with your current vendors. This slide right here does not illustrate, and I know, a few years ago, maybe when we came here, we walked through a process of looking at shifting your entire population over. This does not look at that analysis at all. These are all still voluntary options where your Medicare retirees can either stay on the self-funded Lafayette plan or move to the Humana fully insured Medicare Advantage plan. This slide as well is only pointing out premiums. On the next slide, I'll go through the actual benefits. So your initial renewal came in at $278.79 per employee or retiree per month. That is about a 10.5% increase at about $267,000 more than current on an annual basis. We know that the market has been shifting and changing year over year. So a few years back, United Healthcare started to do something called decoupling. And so I'll get to that in a moment and be able to explain to you the differences. But in the next column, you're going to see where we went back to Humana and we said, we understand there's an increase, but there might be a reason for the board to see that same plan, but with enhanced dental and vision plan embedded in it. That's a full dental and vision plan embedded in it. And that's where that increase came in at 16.93%. Then we went back to Humana and asked, well, can you please release us decoupled options? And so I want to pause there and be able to explain to you guys what that is. CMS rates insurance carriers based on health risks, and they look at each individual member's health score. When insurance carriers submit their individual health scores to CMS, they can submit them with the pharmacy and the medical claims pulled together, or they can submit them to CMS by breaking them out. Typically, retirees that are Medicare eligible and of age have a higher risk score on the pharmacy side. So what they started to learn is if they submit these ratings with the medical and the pharmacy broken out, they receive more funding from CMS, okay? So when consultants like ourselves obviously started researching this, knowing the rules and things of that nature, we said, well, then why can't you give our employer groups separate rates for the medical and the pharmacy? Keep the plan the same, but separate out the rates. We'll combine them on the back end since, it's going out of different buckets. And so, like I said, United started that where they would release a decoupled renewal where all the benefits are the same. The billing is the same, nothing changes from a benefit or a member experience perspective, but yet it decreases the rates. So on the third column, you're gonna see Humana decoupled. We combined the pharmacy and the medical, oh, it's up there, I see it. So you'll see where they have separate rates for the medical only and then the PDP, which is the pharmacy piece. We pull it in together, and of course, Under this scenario, you would receive a $371,000 savings compared to current. Again, we went back to Humana and said, what would that option look like with an enhanced dental and vision program built into it? And it would still create a savings to Lafayette compared to the current premium of $212,000.
Ms. Lana,
Yes.
if there's nothing different in the plan design, the benefits for the decoupled option, then why is the renewal option even on this sheet of paper?
We wanted to be able to show our work and where that starting point came from. We do value ourselves in being completely transparent. This is who we went out to. This is what we received. However, although, and you'll see on the right-hand side, we're showing Blue Cross, which is not competitive, right? We're showing United bundled, or I wouldn't even call it bundled, paired with ESI. So that would be two separate policies. There are savings there, but in our opinion, although United produces more savings than the decoupled options with Humana, we truly believe that the possible disruption to your retirees would not benefit from that savings. So our recommendation would be to move to that Humana decoupled plan with the full enhanced dental and vision benefit embedded in the program. Now, I do want to point out a few things with the decoupled type of plan. All of your retirees enrolled in the Humana plan today would receive a new ID card. It's one ID card, just like they have today, but it just would require a new ID card for everyone enrolled in that plan today. And then they would receive 2 annual notices of change, one for the medical, one for the pharmacy. It's basically a notice that's stamped by the CMS that the carrier sends out to all the enrolled members. And that's it. Outside of what CMS changed for 2027, where they increased the out-of-pocket from $2,100 to $2,400, and I'll go through that on the next page, that would be the only changes to move towards a decoupled type of plan. Any questions on this particular page? We'll go into it in a little bit more detail in a moment.
Do you want to know the separate ID cards for your HC or no?
Okay, so on this page, it just highlights what your current plan design is with Humana, right? So you'll see on the left-hand side, Humana PPO, current voluntary, meaning it's a choice. Right now, that out-of-pocket maximum is sitting at $2,100. That is regulated by the federal government, by CMS. And they are increasing that out-of-pocket maximum to $2,400. So under all of these Humana options, but I'm going to focus again on the Humana decoupled with dental and vision benefit, you'll see nothing changes from a plan design perspective, nothing changes from a formulary perspective and a network perspective, and you'll see that rate decrease from $252.10 to $230.87. This page highlights the actual dental and vision plan. So you'll see with the Humana decoupled with the dental and vision on the right-hand side, it's just highlighting the rates again. But basically, your members will have a $0 dental deductible. Typically, what we see in the market is a $50 individual deductible and a $150 family deductible. But under this plan, it's a $0 deductible. They would have an annual maximum of $1,000. And the benefits for preventative services would be covered at 100%. For basic services, it's like extractions, things of that nature, at 80%. So the insurance company would pay 80% of those. And major services such as endo, perio, crowns, etc., dentures, would be covered at 50%. Under the vision coverage, with this enhanced benefit, you'd have a $10 copay for eye exams and then a $150 allowance for either frames or contacts. And again, this would just be an added benefit if the board decided to move forward with the decoupled enhanced dental and vision plan. Again, this is providing the detail of the Humana current renewal, the other United Healthcare paired with ESI, which would create a lot of disruption from a formulary perspective and things of that nature. But it just shows that the plan design is apples to apples. Any questions on the Medicare Advantage marketing analysis?
So next, we're going to talk about the wellness program. LPSS is investing in an enhanced technology-driven wellness program that is set to begin January 1st of 2027. It is an investment that LPSS is doing for their members. It will be available to all active employees enrolled on the self-insured health plan, along with retirees who are pre-65. The program itself is going to include all the same on-site biometric screenings and flu vaccinations that members or participants were familiar with in 2025. Only this program is going to also include personalized wellness journeys, digital engagement tools, educational resources, and even wellness challenges. The members will also have opportunities to engage in existing programs such as Tria Health, who presented earlier tonight, Quantify, Lantern, and Regenix. Again, those are all existing programs for LPSS members today. We are currently in the implementation stages of setting up the structure for incentives and activities that will be available throughout the program. And so what we've done is we've started modeling several incentive opportunities for LPSS to consider. And after we've reviewed all of those, it came from a perspective of being fair to all eligible participants that an increased annual incentive amount from $250 deductible credit that is in place from 2025, increasing that to $500 as an incentive would be fair for all populations that are eligible for the program. That approach is going to give us several things. It's going to give us the rewarding of participation to engage members to participate. It's going to help us support healthier lifestyles. And it's also, again, going to treat everyone fairly in the incentive. If we look at utilization from 2025, there were 426 participants who met the deductible and requirements. So they actually received that $250 deductible credit in 2025. At the top graph, you're going to see that we've shown a maximum exposure. All 8,300 eligible employees all 426 meet the participation. This year, it would be a cost of about $213,000, 75% utilization, 50%, and then more along the lines of where we think it's going to be about 15% of a cost of about $31,950. The key takeaway here, though, is that this is going to be a utilization-driven program. So we're only spending based on those members who are meeting the requirements of the wellness program and actually meeting their deductible as well. Do you want to add anything?
No, you did good. Okay. This is an area I tried to make it easy for you guys to take a vote on these two items, because I do believe these two items that we just discussed, the Medicare Advantage renewal and options, And then the wellness incentive, which would be increasing that deductible credit from $250 to $500. This is just where I wanted to pull everything together for you guys to make it a little bit easier. Basically, you would pick one from 1 through 5, and then 6 would either be a yes or a no to increase that deductible credit from $250 to $500.
Thank you. Ms. Gardner, do you want to explain this a little clearer?
I'll be glad to.
Thank you.
So basically, the Humana we have currently right now does not offer dental and vision. When you leave as a retiree in the school system, you can port your dental and vision, and then it comes, doesn't have to do anything with us anymore. It comes from your TRSL account. You port it, you pay for it, you do it that way. Currently, if you're a retiree without it, you cannot come back and add it. Taking the Humana Advantage that we would have now, and we would think of it, I use a different word, it's bundled right now, and we would be unbundling it. And please, Gallagher, chime in if I'm saying anything incorrectly.
It's fine.
Basically, those retirees who left with the dental and vision, let's just say they're paying $40 a month for dental, and they're paying, I don't know, $15 for vision. If they're on Humana with a decoupling, now they would be allocated vision and dental, and would be able to get away from paying their voluntary benefit if they kept it when they retired. It would also give the retiree who did not port their vision and dental an opportunity to now gain that benefit from this Humana Advantage plan by doing the decoupling. So if they would switch to Humana. So again, this would be for those on Humana or those who would like to transition to Humana. It does give those advantages both ways, where at a lower premium or than we would be paying if we stayed with it coupled as the renewal. Did I answer that, or did you have any more questions?
No, that was very helpful. Thank you. All right, do we have any other questions? Okay.
And the only other item here is our calendar that we share in every one of these meetings. These are basically all of the tasks and items that we work through on a monthly basis. It doesn't encompass everything, but we try to highlight, everything we do for you guys every month.
Right. Thank you. I just have one more question about what you said earlier. You said you were not local. Do you not have an office here?
No, I'm local.
Okay.
We have, within Gallagher, we have specialists that handle direct contracting because we feel like direct contracting is a whole nother beast.
Right.
It's a different project than what your standard employee benefit consultants do for you. So we have a division that handles that, but none of those direct contracting experts sit locally. And when we found it very valuable that it would be more beneficial to Lafayette to have a local person that knows how to handle direct contracting, because those relationships with hospital groups and providers goes much longer way because of the relationship with Lafayette and those local providers. And so that's, I'm local, but our specialists in the direct contracting space are not.
Okay. My concern is, when the RFP was done, I think part of the reason that the board went with Gallagher is that there was a local presence, and you did suggest direct contracting and steering. And so, and I think it was Mr. Pearson who made that presentation a while ago. But I'm just, to the superintendent, who is paying the extra consultant to do the direct contracting? Is it coming out of Gallagher's fees, or who's it coming? Can you explain that, please?
So we get, for the first year, I think it's $412,000. Is that right, Trish? $415, $3 more. $415,000. So what we do with that is we pay that through the consultant, and we also pay an additional staff member for Trish as far as a credit. So this is not coming from Gallagher, it's not coming from LPSS. That amount on the second and third year also decreases. And Trish, what is it? $230 on year 2 and $230 on year 3. So what we're doing is we're using the allocations that has been given to us by Meritain, and they pay us, and we take that so that we don't have to use our Fund 80, our insurance fund.
Okay, so to be clear, and I'm asking all these questions for complete transparency for the public. We pay Gallagher to consult for us to choose best case scenarios and that sort of thing. And then we also pay Kelly Cox to do the direct contracting, but his fee is coming from Meritain?
It's coming from Meritain.
Okay, thank you. Just wanted to make that very clear for everyone. Thank you.
Can I, I'm sorry, madam, can I piggyback on that? If your experts were to do the direct contracting for us, if you would have said yes, because it was discussed, would that be included in the consulting fee that you charge us?
That's a big question for somebody else to answer, but typically we would charge an additional fee for direct contracting. Now, and I don't have access to the RFP, it's not sitting in front of me, but when we respond to RFPs, we of course give any sort of ideas that we potentially could see that would be beneficial for any potential future client. And it probably was mentioned that is something that is creative out there and being done in the space, and that it's something that you guys could do, but I don't know if it was ever negotiated in our original contract from the start that direct contracting would be involved under our contract.
Right, that would be through the superintendent. You know, the board does not deal in day-to-day operations or negotiations. So, thank you. All right, we have no action on this item, so we're moving on to 2.5. Thank you, ladies. This is discussion and/or action regarding Medicare Advantage market analysis. The Lafayette Parish School System currently provides medical and pharmacy coverage to 837 members under the Humana Medicare Advantage Plan. For the 2026 plan year, the premium rate is $252.10 PMPM, which is per member per month. The Humana decoupled plan maintains all current member benefits while adding new expanded dental and vision coverage. By adopting this plan, district retirees and their eligible dependents will gain access to valuable, previously unavailable post-retirement services, resulting in enhanced coverage and individual cost savings. Additionally, this selection projects a $212,469.84 fiscal savings to the district based on current membership, fiscal year 26-27 budgeted allocations. I'll entertain a motion. Would anyone?
Yes, I'll make the motion. That the Board Insurance Committee recommend the full board approve the Humana decoupled plan inclusive of,
That's
yes,
right.
Yes, dental and
Yep.
vision for the 27 plan year at 230.87 PMPM rate.
Thank you. Do I have a second? All right, I have a motion by Mr. Lejeune, second by Mr. Davidson. All in favor, or no? Do we have to, I'm sorry. Public comment, please. Is there any public comment?
I guess this one.
Yes, just state. your name.
Daphne Villamret,
Thank you.
retiree. And I am thrilled that y'all are considering this and that Gallagher has brought it before us. Because I'm one of those people who is paying the extra. And now I can get my vision and dental included in my zero premium per month. And it's gonna additionally give the board a greater savings than what they're already getting by having us on Humana, because we're not covered under self-funded. So the amount, and for the record, the amount that the board pays on our behalf is less than what the board is paying on behalf of those who are on self-funded, in addition to the amounts that those retirees are paying for their self-funded. So this is absolutely a win-win for those of us who are on Humana, and I thank you.
Thank you, Ms. Do we have any other public comment? Do we have any board comment? Seeing none, call for the vote.
Mr. Davidson?
Yes.
Mr. Lejeune?
Yes.
Mr. Hidalgo?
Yes.
And Ms. Mason?
Yes,
4 for, none against. Motion carried.
thank you. All right, now we are moving on to 2.6, discussion and/or action regarding wellness incentive modeling. On June 11th, 2026, the Lafayette Parish School Board approved a comprehensive wellness program for all active employees, pre-65 members, and their eligible spouses, beginning January 2027. This district-wide strategy will be designed to cultivate healthier lifestyles by integrating digital engagement via the WellRight platform and fitness challenges. As the program begins to take shape, it will feature on-site biometric screenings, flu shots, and go-to-the-doctor primary care engagement program, and a targeted point solution initiatives including Tria Health, Lantern, and Regenix. The existing program currently features a $250 incentive per eligible employee and spouse. Do we have a motion?
Yes, ma'am, I'll make a motion that we maximize, it's recommended that the Board Insurance Committee request board approval to increase the annual wellness incentive to $500 for those who meet the established Lafayette Parish School System Wellness Way criteria.
Do we have a second? Second. Thank you. All right, we have a motion by Mr. Lejeune and a second by Mr. Hidalgo. Do we have any public comment? Seeing none, do we have any board comment? Okay, seeing none. Ms. Chrissy, a call for the vote.
Ms. Mason?
Yes.
Mr. Hidalgo?
Yes.
Mr. Lejeune?
Yes.
Mr. Davidson?
Yes.
4 for, none against. Motion carried.
All right, thank you. That was the last item. This meeting is adjourned.